Good evening, everyone. Assalamu alaikum. Welcome to IMIC Live. Stroke is a leading cause of serious long-term disability and the second leading cause of death in the world. Stroke often occurs with little or no warning, and the results can be devastating. Once brain cells die, they generally do not regenerate, and devastating damage may occur. Sometimes resulting in physical, cognitive, and mental disabilities. In low and middle income countries, which include those of the WHO Southeast Asia region, over 11 million strokes occur every year. This causes 4 million deaths annually and leaves approximately 30% of survivors seriously disabled. For the 70% of survivors who recover, the likelihood of suffering further strokes is greatly increased. Although they are more common in older adults, strokes can occur at any age, and recently an increased number of young age people suffering due to our professional, environmental, economic, and different social impact. So, as a part of our awareness program to lead healthy life, International Medical Information Center, IMIC Limited Bangladesh, and Farrer Park Hospital Singapore jointly arranged this webinar on stroke, recent updates and management. Fairpark Hospital is focused to bring value to people through solutions for holistic healthcare, hospitality, and wellness. And the hospital ensures patients with modern and efficient healthcare services with the current developments in medical technology, treatments, and innovations. Please join us and share your valuable comments and queries during our live sessions. And let's get introduced with our today's highly esteemed speakers from Singapore and Bangladesh to know more about stroke, recent updates, and management. Thank you all for joining with us. And it's a great pleasure that we have two speakers from Bangladesh and Singapore. Professor Dr. M.D. Zillur Rahman sir, Senior Consultant and Coordinator, Department of Neurosurgery, Evercare Hospital, Dhaka. Welcome to our show. Thank you, sir. Thanks for joining us.
Thank you, Farzana, for
So,
introducing so many words. Okay,
just a bit, a little bit information about Dr. Professor Zillur sir. He has completed his MBBS from Singh Medical College and Hospital and completed FCPS in General Surgery and MS from BSMMU in Neurosurgery. He got his extensive training in neurosurgery and general surgery from Institute of Postgraduate Medicine and Research, IPGMNR, and Singh Medical College Hospital, respectively. Professor Rahman is a renowned neurosurgeon and a very well reputed teacher as well as an examiner in different post graduation courses. Thank you, sir.
thank you.
Now we would like to introduce with you our doctor from Singapore Fairpark Hospital, Professor Dr. Chou, Director and Senior Consultant Neurosurgeon, Chou Neuroscience Clinic, Fairpark Hospital, Singapore. Welcome to our show, sir. Thanks for joining us. Thanks for your time. So Dr. Chowning had served the public sector for more than 2 decades as a senior consultant neurosurgeon. He has a very vast experience in neurotrauma, vascular neurosurgery, tumor surgery, skull-based surgery, pediatric neurosurgery, pituitary surgery, and spinal surgery. He is well conversant with both cranial and spinal surgery. He had trained at the Royal London Hospital and was sent by the Ministry of Health when he was awarded the Human Manpower Development Planning for Neurosurgery. Upon his return to Singapore, Dr. Chowney was soon appointed as head of the neurosurgical unit at the National University of Singapore. Welcome to our show, and we are glad that we got the most experienced doctors with us today to discuss on the stroke management. And first of all, I'd like to start with Professor Dr. Zillur Rahman. Before of that, this is Farzana, Chairman, International Medical Information Center. I'll be conducting the whole show throughout the session. Thank you. Thank you, everyone. So, sir, we know that the stroke is a very common disease for Bangladeshi patient, especially adult age patient. But recently, young people also having sudden stroke and get collapsed for the rest of their life. And what actually causes stroke, and especially who are under high risk of having stroke? If you kindly brief on this.
Thank you, Farzana, for asking me a very important and valuable question. Uh, in recent years, we have come across many of our patients who are a little younger than the expected age of stroke. As you mentioned earlier, that a stroke is a disease of elderly, but this is not true all the time, because some certain you should know, or we know all about the stroke. There are some causative factors which are responding, or which are promoting the stroke, such as the sedentary lifestyle, who works more in a sitting position without any movement, that is sedentary position, getting obese, and there are that hypertensive patients who are not treated regularly or irregularly treated. These are the most vulnerable patients, as well as the uncontrolled diabetes mellitus, cigarette smoking, alcohol abuse, and some fatty, that is the cholesterol, high risk cholesterol diet. These are the important factors. And we come across that the young generation or young people, they are, most of their food habit is not so good as elsewhere in the other countries of the world. The junk foods are very popular in our society. The young people are most fond of it. They eat saturated fatty substances, as well as don't work, or physical exercise is less, getting obese, hypertensive, not caring about the taking medicine. These are all contribute to the disease as well. So we come across a good number of patients in a younger age, as you mentioned.
Thank you so much, sir. And that's a very information, I mean, important information to our generation, especially we actually too busy with our work life and balancing our social and work life, and it's really difficult for us to do some workouts. So that's really important in our lifestyle. Also, I'd like to hear from you that it's really difficult for Bangladeshi patients, especially if we are non-background medical sites, and then if any patient is going to have a stroke or a serious patient, how to understand if this patient is, if a patient is having heart attack or stroke. And sometimes we cannot tell that actually what he is suffering from, whether he is suffering from stroke or heart attack. And the first aid treatment from the home is really important before moving to the hospital. So what's your advices to understand the pattern of the disease and the first aid treatment options we can give a patient, please, sir,
Oh,
in
thank
your
you. Very,
opinion?
yeah, yeah. It is a very important question as well. Only there is a misbelief, or belief is that the stroke is a heart disease, but not. This is the brain attack. As the heart attack is a synonym, stroke is also a synonym for brain attack. Only if you follow only four things, then you can understand in your home or any environment that somebody might have stroke. That is fast. We know, everyone knows that fast means F stands for facial weakness. If someone wants to show his teeth or say something, then the face will be deviated. That is the one sign that he may have stroke. A is arm movement. If he asked to show his arm above his shoulder, then some patient may drift, they cannot move the arm. So face, arm, and S is that is the what it stands for, signs of any weakness. Left half or right half of the body is weak. This stands for S. And T is the time when to call a emergency doctor or a hospital. So if we see the patient in a homely environment, and if you closely observe that this any of these, there is the facial weakness, arm weakness, or inability to move some part of the body, then it is a mimic that he might have a stroke. So in easy way we can assume that this patient might have stroke rather than a heart attack. Heart attack, the patient might have pain in the chest, shortness of breath, sweating like this. Or she would not facial weakness or something. So easily we can divide the things whether it is a heart attack or it is a brain attack.
Thank you, sir. And what should be the first aid when anyone is having the stroke from the home?
Home first, if someone is having the stroke or signs symptoms of stroke, he should be rushed to the hospital, nearby hospital, as soon as possible, because the golden time is the first 3 or 4 hours. If it is the patient can be reached in the 3 or 4 hours time, in the first 3 or 4 hours time, then the long lasting effects or results of complication of stroke can be avoided in a good way, because the first hour, first 3 4 hours is the golden time. If we lost this time, then the chances of recovery is less and might have lifelong disability may occur if we not treat earlier. So the sooner the better is the treatment. It should be started as soon as possible. So don't make delay in transporting the patient to nearby hospital.
I see, sir. Thank you so much. স্যার খুব একটা ইম্পর্ট্যান্ট একটা ইনফরমেশন দিলেন, দ্যাট ইজ ফার্স্ট ফেসিয়াল
Facial weakness,
চেঞ্জেস, আর্মের কোনো চেঞ্জ, তারপরে খুব তাড়াতাড়ি কি
weakness
আপনাদেরকে
of
মুভ
the
করতে হবে, টাইম অ্যান্ড সাইন অফ এনি উইকনেস. সো দ্যাট ইজ দ্য সিমটম অফ
right,
any patient having a
first
stroke.
identification of stroke,
Yeah,
right.
so easily anyone can understand. It's a very good tips for our audiences to know. Thank you so much, sir. We learned a lot. Now moving forward to Professor Dr. Chou Ning.
Thank you. Thank you, everyone. I was just trying to share some slides. Yeah. So I'll just run through some of the slides and just to show everything. I just want to emphasize a few things. Stroke is important because it is a major leading cause of death. And the problem is that, as Professor Rahman have said, a lot of the stroke survivors, they are disabled, and the risk factors are same as the cardiac risk factors. So what is a stroke? A stroke is like a brain attack, is a cerebral vascular accident. It can happen either as ischemic due to lack of blood flow to the brain, or hemorrhagic when there's a rupture of the blood vessels. So for ischemic strokes, this happens in 80% of the time, whereby the blood vessels is clogged up. There's a blockage on the blood vessel. Thrombotic is when the plaques they are formed in the brain vessels, when embolic are clogged and migrates from the heart or the neck vessels. But the final common pathway is that the brain cells are deprived of oxygen. So this is what an ischemic stroke is all about. So this is a scan, a CT scan, showing basically very early on the middle cerebral artery. Here is a white MCA sign, and this is an infarcted brain on the right side. Yeah. So hemorrhagic is when there's the blood vessels bleed due to blood vessels being weakened or aneurysms, and there's blood clot within the brain parenchyma. So, for example, this is a blood clot, a large blood clot in the left basal ganglia area. And basically, how, as Professor Rahman has said, how do we recognize a stroke? We recognize a stroke when there's temporary weakness. All these are sudden. Temporary numbness, loss of speech, loss of vision, and the face starts to droop and drool saliva. This is very, very important. And what happens in stroke? There's a golden standard. You must go to the hospital very, very fast. And like Dr. Rahman have said, you must be there within a few hours. For ischemic strokes, 4.5 hours is very important, because if the patient comes in within 4.5 hours, we can give medicine to break down the blood clot. And if within 2 hours of giving the tissue plasminogen activator and the patient is still weak, we push the patient down to take out the blood clot, which is called thrombectomy. So basically, as far as ischemic stroke outcome are concerned, if we are able to give this medicine to break the blood clot, the outcome is much, much better if we give intravenous TPA. For example, what happens if the patient comes after this 4.5 hours to 6 hours? If the stroke is small, we leave it alone. But if the stroke is large, we may have to remove the bone to relieve the pressure. On the other hand, if it is a hemorrhagic stroke, we need to take, if it is a large blood clot, we need to take out the blood clot to save the patient's life. This is an example of a small blood clot. We can leave that alone. But on the other hand, if it is the large blood clot, we need to take off the bone, remove the blood clot to save the patient's life. So in general, large blood clots above 5 by 5 by 5 cm will need surgery, and those below less than 3 by 3 by 3 cm will not require surgery. There's one more type of hemorrhagic stroke, which is the subarachnoid hemorrhage. This is a dangerous form of stroke, and we need to attend to this very urgently. They see this as a subarachnoid hemorrhage. You can see this kind of blood picture, and this is what it calls subarachnoid hemorrhage. And what you can see is that these are due to aneurysms. Now, what do? When the aneurysms, we do an angiogram, we find an aneurysm, and next thing, aneurysm, it ruptures. So what we need to do is that if there's two options, one is to put a clip to stop the bleeding, or we put a coil to stop the bleeding. So example is a 50-year-old man. He had a sudden onset of headache, loss of consciousness. The angiogram showed the anterior communicating artery aneurysm. He went for coiling and was discharged within 1 week. So for example, this is a coil here. Now, well, this is, this is what we do for clipping of aneurysms. This aneurysm, we put a clip there to stop the bleeding. This is what a clip is. We put at the neck, and this is this is just a stroke. What most important is that early management within 4.5 hours, and management after 6 hours. Within 4.5 hours, we can give the medication to dissolve the blood clot. But after 6 hours, if the infarct is large, then we need to decompress the brain. And for hemorrhagic basis, for subarachnoid hemorrhage, we other two options: either we do clipping, or we do coiling of the aneurysm. So the concerns are that because these are high mortality, what we want to do, and 50% are due to chronically disabled, and therefore we want to treat this as soon as possible. Can we put the next slide? And Dr. Rahman also mentioned that how do we prevent strokes? We want to, because the risk factors of stroke and the cardiac risk factors are the same. So we want to manage the cholesterol and have a healthy lifestyle, and of course exclude vascular structural abnormality. Yeah. So I'm just going to load up some ischemics. Sorry. How to switch off? I think just leave it. So basically, what I'm trying to say is that as far as possible, we are talking about strokes whereby we want to have risk factors, control risk factors, like Dr. Rahman have said. We want to control smoking. We want to control the hypercholesterolemia, and do more exercises and move away from a sedentary lifestyle. Yeah, yeah. So these are what the basic things of stroke that we talk about. Thank you. Yeah. No, that's really, yeah.
Thank you so much, Dr. Chou Ning. We just got to know the basic information regarding stroke. So, would you like to discuss on the recent advancement of the treatment option or advancement of treating a stroke, especially the surgical procedures?
Yes. Um, Basically, as far as we are concerned, the if it is hemorrhagic stroke, if it is a large clot, we take it out. If it is a small clot, we leave it alone. If it is for aneurysms, the first choice is to put a metal coil, as I showed a picture earlier on, or if can put a clip. Now, as far as ischemic strokes are concerned, whereby there is a lack of blood supply to the brain, now Dr. Rahman has already emphasized time is of importance. You bring the patient to the hospital very rapidly, and within 4.5 hours, we can give a medicine to break down the blood clot in the brain. So this then brings about much better recovery for the patient. These are for patients who have reached hospital in the first 4.5 hours to 6 hours. On the other hand, if the infarct is already established after 6 hours, if it is a small infarct, we leave alone. If it is a large infarct, because the infarcted brain will swell, we have to take off the bone to relieve the pressure. Now, sometimes we know that, and in ischemic strokes, the major management is medication. We give either aspirin or we give either single antiplatelet therapy, which then sometimes we may need to add on double antiplatelet therapy. But on the other hand, there's also some patients with, after a while, you are on the maximal therapy of double antiplatelet therapy, or sometimes some patients are even on the what they call the NOACs, the novel oral anticoagulants. And some patients still continue to have ischemic symptoms. That means they have transient ischemic attacks like temporary numbness, temporary weakness. Now, for this subgroup of patients, what do? We sub-select them, and we do what we call a certain test to look for cerebral vascular reserve. That means basically you find that there's not enough oxygen in the brain. So for this group of patients, what we can do is that we can do a brain bypass. We use the superficial temporal artery, and we do an anastomosis into the middle cerebral artery, and we do a bypass to increase the blood flow to bring into the brain. Just like for the heart, when there's not enough blood supply, what we do? We can either do balloon or we can do a cardiac bypass. So for the brain, we can also do a bypass for this subgroup of patients. But the criteria for this is that must always check to make sure that basically there's a lack of cerebral vascular reserve, and and the patient must be symptomatic. So for this group of patients, if we don't do the bypass, they end up with a major stroke. So a bypass is also one of the options that we can offer to the patient. Yeah. Thank you.
Thank you so much, sir. Dr. Zillur, sir, would you like to add something or anything to add with this
Yeah,
discussion,
yeah.
please?
Thank you, Dr. Choning.
According to a Bangladesh perspective.
Yeah, yeah. This is the same thing. We are also doing this because this is a universal thing. These are to be followed or elsewhere. But one thing is important. Getting the antiplatelet or anticoagulant therapy, if it is taken in large doses or for a long time, that might have a chance of hemorrhagic stroke. That is a big concern. So it should be calculated and frequently checked. The warfarin or the anticoagulant drugs which are given to the patient, they should be checked regularly. Otherwise, this patient might have come with the hemorrhagic stroke as well. Once comes with the ischemic stroke, can come to the hemorrhagic stroke later on. So you should be very careful. That's
Yes.
I want to add.
Absolutely.
Yeah, yeah.
Absolutely, sir. That's really important to know. And as we know that there's always a chance that if you are having a first stroke, there's a chance of having the second time stroke. So, is there any preventive procedure or treatment to protect the patient of having another stroke, or the medicine is the only supplement that can help the patient to survive for the rest of the life.
I
Uh,
think
Professor Zillur.
Okay, you can supplement. Okay, the thing is that the treatment consists of the some taking of some medicine, as well as prevention also consists of some preventive measure to come into the next course of action. That is the way of life, that is sedentary life. It should be changed. That is the regular doing exercise, avoiding cigarette smoking, avoiding treating the hypertension precisely, control of diabetes mellitus, avoiding cholesterol rich food. So these are the methods and ways by this taking these into account, the patient having a stroke can prevent the further stroke. Not only taking the medicine, but also the lifestyle should be changed as well. That is I want to know. Please supplement, Dr.
Okay.
Chorin. You wanted
yes,
to say?
I
So, Dr.
agree, Professor.
Swami.
I, I agree with Professor Rahman absolutely. The key emphasis is that prevention of the stroke and also the risk factors of stroke and also the heart are exactly the same risk factors. And
Right.
basically, if you can control your lifestyle modification, you control your diabetes, your hypertension, your all these are very, very important. Now, on
Right.
top of that, basically, yeah, so these are important factors. Now, in many countries, you can follow on like a 5 year period. What's the chance of having a recurrent stroke? After 5 years, some countries are at about 55%, some countries are at 70%. So if you're able to control your hypertension, your cholesterol,
Diabetes.
and your diabetes, you can bring down the risk to the patient
Yeah.
much by a large percentage.
Yeah.
Very,
Yeah.
very important. Yeah.
Very true. Very true.
Sometimes it has been said by our patients that, or the family, that after having a critical surgical procedure like any transplant or anything, that actually maybe was not positively done, or it was not successful. Later on, it impacted on the patient, and patient had a stroke. So, any critical surgical procedure has any impact on this on the stroke, or emphasizes to have a stroke, the risk factor, and if any patient already had a stroke and needs to have any surgical procedure, critical surgical procedure, what they should be concerned about, and the success after the surgery.
Okay. I think
I'd like to go with Professor Choning first, then Zillur sir, if you can get.
yeah,
Okay.
I think if the patient, two things here, right? I think you mentioned if the patient have any procedure and then is that related to stroke, I think that is not really associated. But on the other hand, if a patient had an ischemic stroke, then the chances of having you want to do a surgical procedure within the first 6 months, that is associated a much higher risk of stroke. So if any patient have an ischemic stroke, so for the next 6 months, try not to have any surgical procedure because the chance of having a stroke may be up to even 30%. Now, in general, if a patient have a stroke, you must, because it is basically your blood vessels, always check out the heart, make sure check out the risk factors of a myocardial infarct, and also try to stay away as much as possible, no surgical intervention. But sometimes patient needs a very
Emergency surgery.
living procedure to be done. So I think the most important is that the doctors will speak to the family and have very clear guidelines about what they really, really need to do to save the patient's life. It's just about risk and benefit.
Yeah, very true. He has mentioned clearly this is the risk factors, because once having a stroke, the patient might have having a stroke in the next time. So we should be very careful, because the stroke patient might have other disease, we say it comorbid condition. He may have chronic kidney disease. He may have heart failure. He may have other condition as well. So there is always chance of having a stroke and the vulnerable situation is very serious after stroke. So better to avoid any routine operation for some time. Then if emergency is there, then it should be taken seriously with the precaution that he might have a stroke. So treat accordingly.
Yeah, exactly, sir. Because during the case summary of the patient, it is always mentioned that this patient had a stroke. That
Right.
is taken care of by the doctors very carefully. So that's a very important information from your side. Yes, absolutely, it's very important to check the diagnosis and then treat for the surgical procedure. And we got a question from a patient about that if the stroke is a hereditary and if father or mother has this disease and I mean the children can easily get this disease in near future. So what should be your advice?
I should respond? Should I?
Yes,
Please.
please, sir.
Can you hear me?
Yes,
Yes.
sir. Yes, please,
Oh,
sir.
oh, okay. If someone having a stroke in his family, that is hereditary, yes, it is a important to know that some families runs with the stroke in series. So we should be careful and try to avoid or prevent the possible risk factors. To avoid to risk factors and try to maintain that, and try to ambulate, that is the exercise, regular exercise, and avoiding the risk factors. In this way we can sometimes avoid, but in some ways it is inevitable that with all precautions there might have chance of stroke. So once it
Yes,
is there, it should be treated as early as possible. That is the important message.
I
yes,
think it is important to realize that there are certain the because of the genetic variation in the general population, there's a subset of this population which have innately high cholesterol. They call it familial hypercholesterolemia. So in this group of patients, you must always remember that we produce 80% of our cholesterol is endogenous. That means it's produced by our own body. So exogenous is only probably about 20%. So when we exercise, when we take cholesterol medication, we are affecting the 20% to reduce it. So some families with very high cholesterol, yes, you can bring down a little bit, but there's a limit how much you can bring down. So in this group of patients, it was very important to have exercise, to control your weight, control your high blood pressure, control your diabetes, which all can, worsen the situation. So like Dr. Rahman said, yes, it's very important. Yes, we do whatever we can, but sometimes it still happens.
Yeah.
exactly, sir. Maximum of our diseases, I think, that can be hereditary and like cancer, stroke, heart diseases. That can be from the family backgrounds.
Right.
Yes.
Yes, exactly. And let's discuss about brain tumor because I know stroke is discuss about the stroke. That's a very common disease. But yes, you both are expert in this field, so I think we should not lose this option. I mean, chance to get to know about the treatment options about brain tumor. And first of all, I'd like to know. Sometimes the clinical presentation of brain tumor mimics that of stroke or vice versa. I mean, how to understand if it is the symptom of brain tumor or stroke? Is that, I mean, how to determine? I'd like to hear from Professor Zillur Rahman and then Dr. Chou, please.
Okay, very important and pertinent question. Stroke is a sudden onset, but in brain tumor, there must be a history for some time. Say, headache. Hey, it continues for, say, for 3 months or 2 months like this. Headache, vomiting, and unconsciousness and seizure. These are the more common symptoms of a brain tumor. One-sided tumor related to the opposite-sided weakness or dysphagia, difficulty in speech like this. So it takes some time, say a history of some months or maybe days. But in stroke it comes on catastrophically, sudden onset. So in this way, in a simple word, we can differentiate primarily that it is a stroke or a brain tumor. It takes some time to understand the origin of brain tumor. It takes some time.
Yeah. I totally agree because some symptoms like headache will come in, but these have got history. It takes time.
Yeah.
Then tumor presents either in two ways for the brain. One is a localized effect on the brain. Once the tumor is localized, the localization, that area will affect the brain, whether will that area of the brain, would it affect the any weakness, any visual problems. If the patient complains of vision, then you know is you think along where the visual pathways are. If it is along near the motor area, you think of the opposite motor area, where how it presents. Sometimes they present weakness in the arm, in the leg, and you tend to know where it is. Sometimes some tumors, when it is big, will then have generalized headache symptoms like generalized headache, or sometimes when the tumor blocks off the fluid pathways in the brain, then that can also cause generalized headache like nausea with vomiting. So the history of the patient becomes important, and but in general, it is not sudden. It is more gradual. Of
Right.
course, some tumors are they grow very fast. So like a malignant brain tumors like gliomas, if you have a short history of 3 weeks, 4 weeks, that doesn't augur very well. But on the other hand, the patient has symptoms for the last 6 months, 9 months. Generally, you know that it's going to be a more what we call not so aggressive tumor rather than as opposed to be a high grade glioma. Yes.
Right.
I see. Okay. So, is there any inter relationship between the cerebral ischemic stroke or the glioma?
Stroke.
Generally, no,
No,
different
no,
things.
no.
No,
The two are
it
different
has
things, right?
not.
Two different
No,
things.
Two
no
different
relationship.
things.
Yeah.
Okay. So, a patient actually asked a question. I had a stroke last year. After that, feeling short-term memory loss. So, is this the impact of the stroke, and is it could be more intense in future?
Usually, the memory loss may be transient, and in course of time, this can improve with the time. So might not having a long-lasting effect in stroke. Some temporary memory loss may be there, but after some time, it will be recovered.
It will
I
also
see.
depend on the extent of the stroke. So if the patient can tell you and talk to you and say that you have this, that also tells us that the stroke area is not very large. Number two, the patient still has insight. That means they can understand their own situation and can perceive and can have understand their own situation. So like in this kind of scenario, I agree with Dr. Rahman that it should improve.
Yes. Sir, sometimes for the children, I know Dr. Chowming is also specialized on the pediatric tumor treatment. If any patient, children genetically gets a brain tumor by bone, so is it possible to get any brain tumor by bone, or and what is the treatment options they have, and what is the success of the surgery after the tumor surgery for for the especially for the children patient?
Okay. In children, the basically most of the tumors in the children are those the tumors that develop in the back of the head. So in the tumors in the back of the head are things like your medulloblastomas. Those are the much more common. Now, I'm just talking the most common ones. Now, of course, there are some tumors which are near the front, which is near the optic pathways. But let's talk about the tumors in the back of the head first. The most common ones are the medulloblastomas. Medulloblastomas are basically the outcome is best if you can go in and excise at least 90% of the tumors. The reason for this is that medulloblastomas, basically, once you are able to achieve to take out at least 90% of the tumors, then you have a higher chance of giving chemotherapy and radiotherapy. But the most important for this is the age group. The age group is basically 4 years old. Because in children below 4 years old, basically you need to give salvage chemotherapy until subsequently you can give cranial spinal irradiation. So that's for medulloblastomas. Other tumors in the back of the head, like ependymomas and also astrocytomas. Now, astrocytomas are pretty benign. If you excise total cure. Ependymomas are more tricky. You need to really take out all the tumors because in ependymomas is not sensitive to chemotherapy and radiotherapy has limited success. So on the other hand, tumors in the front of the head, things like your craniopharyngiomas and optic nerve gliomas, craniopharyngiomas, you got to take it out. In the optic nerve gliomas, nowadays, now you biopsy, you confirm it, you are more leaning towards chemotherapy and possibly some radiotherapy.
Exactly, sir. So, I mean, this is a very crucial thing because when a child gets treated with brain tumor, and they actually wants a hope from the doctor, and it's a very critical treatment for any family emotionally and definitely financially.
Yes,
So,
very emotive
yeah.
when operate on a young child. Yeah, but
Mm.
for medulloblastomas, when you are able to excise greater than 90% and then followed by chemotherapy and craniospinal irradiation, I have patients that survive to about in the into the 20s. But the problem is that when they go to that to about above 20 because of craniospinal irradiation, they tend to have small little meningiomas because of the radiotherapy. So and their growth are a little bit stunted because of the craniospinal irradiation.
I
Right.
see. So, if the radiation extra treatment is going through whether for treating brain tumor, can it
Yeah.
increase the chances of having stroke? It,
Um,
I mean,
Not really stroke, but more about the radiation-induced meningiomas. Lah. Yeah. But of course, if you at the longer the survival, because with radiation, the vessels will be a bit more sclerosed. But
mm,
I think you will see if they really reach the 40, 50 years old, yes, I think there will be higher problems with that. But so far, when you be, I'm very thankful they can live to 20 plus 30. Yeah.
Yeah,
I
yeah.
see.
They can live. I
Uh,
have a patient who has followed up for last 20 years, having a medulloblastoma
Yes.
completely removed and then irradiated. He is
Yes.
now doing good.
Yes.
so that's actually your treatment, and Bangladesh actually improved a lot in terms of
Yeah,
treatment. The advancement
yeah,
is really great, and that's why the stroke patients, even managed by the doctors like Zillur Rahman, very nicely and very successfully. I must say successfully. So, Professor Zillur Rahman, sir, I just would like to know hear from you that when any patient diagnosed with a benign tumor, what should be the treatment approach? Any surgical procedure, or initially you consider radiation to shrink the tumor and then for the surgical procedure? What should be the
no,
actually treatment protocol?
yeah, for a benign tumor, say if it is a small one, it should be not treated. Just wait and see how long it behaves. If it is say it is a meningioma in a small location, convexity meningioma does not giving any symptom, just incidental finding. There is no need of any treatment. Just follow it up. If it causes the symptoms and raised pressure symptoms, then it can be intervened. If for benign tumor, it should not be irradiated. Benign tumor is mostly treated by excision of the tumor and for followed by biopsy. If the biopsy comes as benign, then it is okay. There is no need of any adjuvant treatment. But it comes at malignant tumor, then according to the criteria and location, it should be treated according to radio or chemotherapy like this.
Yeah. I totally
I see.
agree.
So,
For benign
sir,
tumors,
yeah,
for benign tumors, we just follow
Professor.
it up. Unless the benign tumors is near the optic nerve or any eloquent areas, important areas. Otherwise, benign tumors can be followed up. And in fact, sometimes the meningiomas, they are so calcified that they don't grow at all. So we
Right.
just follow up. Yeah.
Just follow up, right?
Exactly. Sir, the last topic, everything we already covered since it's a neurosurgical discussion. So, the spine, when a patient should, I mean, for young age patient, if they have any problem with the spine, it is not advised by the maximum neurosurgeon for the surgery procedure. But actually, in what situation you consider or advise any patient to go for the surgery, and what is the outcome of the surgery? Professor Zillur, sir.
This is for lumbar spine or cervical spine. If it is say so for lumbar spine,
I mean, both in both cases. You wanted
Uh,
to tell.
okay, let me clear it. In case of lumbar spine, when the patient complains of certain things, that is that we refer it as a criteria for absolute surgery, for indication of surgery, I should say. The indication of surgery is a, a patient having a weakness or paralysis of lower limbs. That is a number one indication. If the patient complains of cauda compression, cauda means weakness of all the two limbs plus as well as bladder and bowel control. If it's lost, then it is a surgical emergency. If a patient having a single motor weakness, then it comes into a consideration of surgery. And if the pain is so
Okay.
severe that it cannot be relieved by any conservative means, then it is a indication for surgery. If someone have to leave the normal job and have to wait for months together for treatment, then it is an indication of surgery. So these are the four conditions where we need a surgical decompression of a lumbar spine. In case of cervical spine, if it is conservatively treated and with the traction and physiotherapy, it is okay. There is no pain, no radiation. Then it is good. And in 90% cases, these are not required any surgery. But in case of cervical spine, if it compresses the cord, that is a cervical, that is the we say myeloradiculopathy, that is the weakness of the limbs as well as severe excruciating pain, not relieving with any means, then it is an indication of surgery. So, in short, these are the indications of surgery where we can do the surgery. Otherwise, in most of the cases, in 90% of cases, this does not require any surgery for degenerative cases as well.
I agree. I agree. I think in cervical spine, the indications are if there's weakness, yes, then you could consider the surgery. Otherwise, if it is for pain, I wouldn't. I would my first line is analgesia, physiotherapy, and of course, sometimes if the patient has got long-term intractable pain, they
Yeah,
cannot leave, cannot work, they cannot sleep.
yeah,
They
able to
just
sleep.
cannot. They just cannot function. So
Yeah,
in these kind of cases, we deem it as failure of medical therapy. So in
right,
failure of medical therapy, we can decompress. Of
right.
course, the decompressions are for two reasons. One is for radiculopathy, which is the nerve root, or sometimes for myelopathy,
Men,
which is compression of the spinal cord. Because
yeah,
sometimes patients, they are very unsteady. The sensation is obtunded, and the gait is affected. They have the control, the bladder bowel is also affected. Then we need to decompress the spinal cord and fix it for the patient. So these are the indications. And for
yeah,
lumbar spine, Dr. Rahman has already mentioned all the critical, like cauda equina or long-term intractable pain. There's only probably one other factor is that sometimes patient has got just back pain, right? Back pain, if the patient has back pain of instability, that means when they move, they go from the sleeping to standing position, they just have severe pain. So we do a flexion and extension view to see whether the spine is opening up. So if the spine is opening up, then for those, no matter how you do physiotherapy, conservative management, the pain will stay. So
right.
for those with instability, we tend to fix it
Fix
properly.
it,
Yeah,
fix it. Yeah, totally agreed.
yeah.
Thank you so much, sir. I mean, I think maximum of the topic we already focused on the basic discussion. We got more questions, but already we I've got the answer from you with the whole discussion. At the very last moment, I know both of you are very busy with your, I mean, clinical work, and that's a working day. Usually, we do our session in the off day, but yes, definitely in near future we'll do more sessions with you, sir, on different topic on brain tumor or any
Okay.
advancement we have in near future. Inshallah, we believe that there will be. So the
Okay.
Most
last
happy to.
yeah, so the
Yeah, I will
last
be happy.
Yeah,
I will be
very
yeah,
happy
happy
to.
to,
absolutely,
yeah,
sir.
yeah, to having Mr. Stone in with me and also you. Thank you for your endeavor.
Yes,
I
absolutely,
must
sir.
welcome you.
And I'm waiting for the good day when all of us can meet the impact of globalization. Then we will understand to treat
Yeah,
the
yeah,
international patients in a collaboration. Sir, the last discussion from your side, what should be the advices after all these discussions to our audiences? How should be their lifestyle and what to improve? So the last words from the both of you. First of all, I'd like to start Professor Chowning and then Zillur sir.
Okay, I think the only message I want to leave home to for everyone to bring back is that stroke is preventable, because I just mentioned earlier on that the risk factors for stroke and the cardiac risk factors are the same. If you are able to control our lifestyle, like with behavior modification, control the blood pressure, control your cholesterol, control the weight, control the exercises, and control your diabetes. And then also, of course, if cost is not an issue, we can do a screening, we can do a MR angio to exclude vascular abnormality, to AVMs. I think then that will go a long way to screen and prevent strokes. That's all I say. Thank you.
Thank you, sir. Sir.
Uh, yes, thank you very much for your nice comments. I have seen that he has already given the light insight. That is the only thing. Don't get panic. Once the disease strikes, then correct in a silent way and in a patience way to treat the patient and to calm the situation and to try to avoid the unhealthy lifestyle. Make a healthy lifestyle, then it will be many diseases can be prevented, not only stroke, other diseases can also be preventable. That is the main message.
থ্যাংক ইউ সো মাচ থ্যাঙ্কস ফর ইউর অ্যাডভাইসেস আমাদের এই লাইভের অ্যাকচুয়াল মোটিভ হচ্ছে অ্যাওয়ারনেস ক্রিয়েট করা এবং আমরা এই ডিসকাশনগুলোর মাধ্যমে যে বেসিক যেই ডিসকাশনগুলো আমাদের হয়েছে আজকে এর ম্যাক্সিমাম ছিল আমাদের লাইফস্টাইল, আমাদের
Modification.
হেলদি ইটিংস, আমাদের পুরো ব্যাপারটা আসলে যে কোনো ডিজিজ আমরা তখনই অ্যাভয়েড করতে পারবো যখন আমাদের লাইফস্টাইলের ইমপ্রুভমেন্ট নিয়ে আমরা আরো কনসার্ন হব, হেলথ নিয়ে আরো কনসার্ন হব, আমাদের ইটিং হ্যাবিটস, আমাদের এক্সারসাইজ আরো বেশি আমাদেরকে
Exercise.
একটু কনসার্ন হতে হবে। অ্যান্ড আমরা রেগুলারলি এই ধরনের প্রোগ্রামগুলো করতে থাকবো বিকজ উই বিলিভ দ্যাট অ্যাওয়ারনেস ইজ the most important thing before you go for any critical treatment or any better options or any advanced treatment management. So we don't want that you go through with this situation. But still, if you face this type of diseases or any critical situation, please contact with IMIC for any of your queries. We can discuss with our panel, with our doctors from Singapore, with our doctors from Bangladesh for any of your assistance. Please follow our page, IMIC page, and we will update you on our future programs. Thanks for watching us and thanks for joining us. Thank you, both the doctors.
Thank you.
Thank you very
Thank
much.
you both of you. Thank
Thank
you.
you.
Thank you.
Take
Thank
care.
you.
See you.
See you.
See you, sir.